All right, still looks like we're waiting for people to get logged in.
See, Alejandro Cabero has connected. So good morning, Alejandro.
Yes.
And good morning, Felicia. Yes, we can read your texts. So right now, as those of you are connecting online, the cameras and the audio is set to hear and see our panelists. So if we can't see you, we can still hear you if you type into the chat box. But yeah, feel free to say hello. We'll give it a couple more minutes and let everyone get connected. But so far, it looks like people are connecting right now. Good morning, Shannon. I think the sunshine is waking up everybody in a really good mood. It woke me up in a good mood. Yes, Isabel, we can see you in the chat box. So thank you for saying good morning. So it looks like some people have already gone out for a walk this morning. So congratulations to you. I'm still sitting here at my computer. Edna, I believe you're having maybe some mic and camera issues. No worries. As long as you can hear and see us, you can ask your questions in the chat box. So as everyone else is connecting, I think we are getting ready to get started in just a moment. But it's just important that you can see and hear us. You'll see 6 images here on the screen. But as long as you can hear us, that's what the format is going to look like this morning. There's definitely an opportunity for you to ask questions. So if you are not yet familiar with the chat box, if you hover over your screen, you should see a little bottom button on the bottom where it says chat. And that should pop up your little window, and it stays on the right-hand side of your screen. Oh, sorry, yeah, you will see 5. Then Gabriela's camera is having a little bit of technical difficulties, but as long as you see 6 boxes or 5 images, you're good. All right, we will go ahead and get started. It's 9:05 this morning. My name is Celia Ruiz, and I'm with United Healthcare. It's one of the CanCare or the Medicaid health plans in the state of Kansas. Today's webinar, Telehealth for Immigrants and Refugees, Opportunities and Challenges, is brought to you by Communities Concerned for Immigrants and Refugees and is sponsored by the Reach Healthcare Foundation. So we appreciate and thank Reach Healthcare Foundation for putting together what we call CSER. You may hear CSER in the future as well, but Communities Concerned for Immigrants and Refugees. We had planned a series of in-person workshops or forums for this year, but we, as so many others, have moved to an online platform in response to COVID-19. For some of us, Zoom is an everyday thing. Cameras, emails, and also even the chat box on the right-hand side where we say, can you hear me? Can you see me? Resetting passwords, logins, accounts. All of that may seem very similar to so many of us, but in reality, it's not typical for so many of our families that now we are asking to join their healthcare providers online. So before we do jump into our panel of experts, we want to make sure that the platform that we're using today is understandable and accessible to you. Today's webinar is being recorded and it will be posted on the CSER, Communities Concerned for Immigrants and Refugees, social media outlets, and online. So this will be recorded. On your screen, you should see the images of our panelists. You'll see 5 images, but 6 boxes because Gabriella's camera wasn't working this morning. That's a reality of telehealth and connecting digitally. Sometimes things don't work the way that they're supposed to. So I think this is an awesome example of what can happen and what does happen. Everyone has been placed on mute. So if you can't see yourself on the screen, that's intentional. We encourage you to use the chat box on the right-hand side. Feel free to plug in your questions there. I'm glad people are saying good morning. Glad to see that and glad to see that you're connected. So please be sure to use the chat box. If you have a question, we will answer all of these questions towards the end. But when you ask your question, we do ask that if you can include what city or what type of work you're referencing. This webinar has been shared online. And again, when you share something online, you really don't know where it's ending up. So I do hear that we had someone register from Charlottesville, Andrea, is that correct? So yeah. So this is going outside of the Kansas City area, and we want to make sure that that answers are relevant to the community that you're serving. All right, so the chat box is on the right-hand side. If you are not familiar with the chat box, please know that all of the questions that you ask, and if you want to hover over the chat screen and pretend to type something, you'll see that you can send a question to all panelists and attendees, or you send it to, you can send it to Andrea Perdomo Morales. All of these questions will be gathered. We'll answer them at the very end. And just as an FYI, all of these answers and questions, all of these questions, our host will have access to them after the session is over. So even if you were to send me something privately, and you can send something in Spanish, the host will be able to see that. I think it's just a good FYI because as we connect to other Zooms for other meetings, sometimes we are never told that those questions end up in another spot. But yeah, take your time with those questions. We look forward to hearing from you all. So Andrea, if you can kind of wave your hand there, and that way they know that you're going to be the one who's going to be looking at the questions, and you'll be collecting them, and you'll be helping out with those at the very end. So let's go ahead and dig in. First, we're going to do a quick round of introductions from all of our panelists, and then we'll dig into some specific questions about technology, language, and culture. I'm excited to say that we even have a patient perspective on what all of this really looks like for our families. So let's go ahead and get started. Dr. J.C. Cowden, would you like to give us a brief introduction of yourself?
Sure. Thanks, Celia. Can you hear me okay? Great. Yeah, I'm J.C. Cowden. I'm a general pediatrician at Children's Mercy Hospital. I work there in primary care, and I serve primarily Spanish-speaking families and their children, and also teach bilingual residents there at the hospital. In addition to that, I work in the Office of Equity and Diversity, where we work on a broad set of issues around health equity, both within our organization and in the community. And I'm going to pass the microphone over to Gabriella Gardner to introduce herself.
Good morning, everyone. My name is Gabriella Gardner, and I'm the Director of Language Access at Truman Medical Centers. TMC is an academic medical center and safety net hospital, and we do serve a very diverse patient population. Our patients come from all over the world and they speak 95 different languages. At TMC, our staff interpreters have been on the actual and virtual front lines of the COVID response. I oversee a team of 30 staff Spanish, Arabic, and Somali interpreters and cultural health navigators who usually work on site providing in-person interpreting. However, in response to the pandemic, we had to quickly transition from in-person to other interpreting modalities such as telephonic and video to support the shift to telemedicine. Now, approximately 90% of our interpreting work is done remotely, and our interpreting staff has continued to support over 400 language contacts with limited English proficient patients every day since the start of the pandemic. Although this is still a work in progress, I'm here today to share with you some of the lessons that we've learned along the way.
All right, Dr. Johnson, can you please introduce yourself?
Good morning. Thank you. Yes, Chelsea Johnson. I am a general pediatrician at Children's Mercy Hospital. I've been there for 20 years now. I've worked in the emergency department and urgent cares, as well as a hematology and oncology. I've spent the last 4 years providing after-hour urgent care for the Medicaid population that we take financial risk for, and trying to provide them with telehealth opportunities to get them back with their medical home provider, and hopefully be able to provide care where they can't get it in the urgent care, or to try and avoid having them go to the emergency department. Since the COVID 2020 came about, we have made a lot of movement within the organization to expand telehealth services throughout, where we now have about 70% of our visits are via telehealth throughout our organization. We do have a COVID hotline, and I've worked with our language services folks to make sure that we have all of our web pages and interpreters available, so that we can provide, if not video conferencing interpreters, at least telephonic interpreters. And as we continue to grow our telemedicine platform, we hope that we will continue to expand that and include that in some of our telemedicine webinars and modules, as we educate our entire organization about the different culture of just telemedicine, and making sure that we incorporate all the different things that we need to consider with our various patient populations. So I'm happy to be here and impart my 2 cents and my experience with telemedicine.
Great, thank you so much. And then lastly but not least, we also have Iran. Iran, would you like to say hello? And I know that we have your, yeah.
Hi, my name is Iran Ortuno, and I'm a chef.
Well, Iran, we appreciate you joining us, because I know that you'll be sharing a little bit later, what it's like from a patient's perspective. So there can be all of these plans, on how we want to implement, telehealth, but we want to make sure that we're hearing from our families. So we'll go ahead and just jump in real quickly. So Dr. Cowden, can you start us off by telling us about what is at stake for immigrant and refugee communities as our healthcare and social support systems shift rapidly to telehealth because of social distancing, and why this is important?
Yeah, sure. And to start with, I wanted to talk very briefly about a couple of terms. We've heard both of them already this morning in the webinar, telehealth and telemedicine. And these terms are related to each other, but they're not exactly the same thing. When we talk about telemedicine, we're talking specifically about giving medical care at a distance. So for example, a doctor may be at one site, a patient at another, and they're connected by video and by sound. Or you might have a primary care provider with a patient in one site, and they connect to a specialist by video so that they can all have a visit together. Telehealth is a much broader term, and it includes the use of multiple audio, video, and digital technologies to deliver all sorts of healthcare and health services and health information to those who need it. And today what we've imagined is really talking broadly about telehealth. And that includes the medical visits in telemedicine, but it also includes connecting community members to social services, to behavioral health care, to written and recorded information, and more from a distance. So both for our attendees and ourselves, I think that's important to remember. But to your question about what's at stake, as we've shifted very rapidly to telehealth because of the need to stay apart from each other as best we can, For immigrants and refugees, there's a great deal at stake, which many or perhaps all the people on this webinar today will already know, particularly if they're working to directly support such families and individuals. Pre-pandemic, there already were significant barriers to accessing healthcare and health information, social services that we're all aware of, and those created important disparities in healthcare and health outcomes for immigrants and refugees. And we're going to talk in some more detail with our other panelists about this. In particular, language and cultural differences already existed, of course, pre-pandemic, and could be a barrier to care. And Gabriella will talk with us more about that. Technology access, connectivity differences for certain families in our communities already existed, and Chelsea's going to talk more about this. But there also are policies that affect access to care and services. At the federal level, of course, there's immigration policy, but there are also policies at the state level that relate to insurance coverage and even directly to telehealth coverage, or telehealth parity, as it's called, that also impact various communities in different ways. And so all of these barriers to health and healthcare access, of course, they already existed before the pandemic, but what we're seeing over the last few weeks is that many of them have gotten worse. And seem to be making disparities worse for many immigrants and refugees as we move more and more to telehealth interactions. So this puts the well-being and the health of thousands of families and individuals throughout our community at even greater risk than we were already seeing before. But on the other hand, the other piece that's key for us to remember is that there are opportunities that come with telehealth that may be particularly beneficial to immigrants and refugees. For example, we found that for those who can get connected, the ability to get some types of care or information without having to go to clinics or other sites where they may have the fear of being apprehended or detained if it's an undocumented immigrant, or they're simply far away and it's not practical to access that information or care, has been a really important opportunity. And so is the chance to have a provider get to know where a family lives. I've had this happen myself, where especially if you already have a relationship and a bond between a provider and a family or an individual, having that ability to kind of do a house visit or a house call can be very powerful. And certainly in some cultures, that human personal connection is of particular importance between a care provider and the family. And it also gives me a sense as a provider of where a family lives and what they might need. So there are benefits that are really powerful. We don't only see challenges and barriers here. But really, getting right back to what's at stake, it's the health and well-being of our immigrant and refugee community members. And all of us who are hoping to support and serve them in their needs have an obligation, I think, to push forward so we can overcome these challenges, and also to look for ways to fulfill this promise and opportunity, the positive side of what telehealth can bring. And hopefully that's what we can explore more here today.
So what is happening with telehealth at the PCC, so Pediatric Care Clinic, Children's Mercy clinics, the satellites, and where have you been talking to, where you've been talking to providers focused on immigrants and refugee care? What's working, what's not working, what's happening at Children's?
Yeah, I know others on the panel are going to have plenty they can say about this as well, but I've certainly been learning more almost every day about the many telehealth approaches that have emerged through conversations we're having with our community partners in our region, and also through weekly conversations that I've taken part in with a national group of pediatric providers that is focused specifically on telehealth and health equity. And it's really just a chance to get together and share, what's happening, what's working. At Children's Mercy, as Chelsea mentioned already, we were able to move really quickly into telehealth appointments because we happen to already be using a platform called Teams that's from Microsoft, which we used for video conferencing and sharing files and things like that, that we were able to ramp up very fast. It's a HIPAA compliant platform, so we could be confident that interactions were private and confidential. We have a telemedicine group that uses specialized equipment and software to do telemedicine across several states, but that wasn't really something that could practically be scaled up the way we need to provide all the visits we wanted to try to provide. The upside to this approach was that we already had this software, and a lot of employees could learn it really quickly. The downside has been that it requires families, most families, to download an app. on their side of things to be able to connect to an appointment or to an interaction. That's not true of all platforms out there. But with this one, it's one of the downsides because when we're working across a language or a cultural difference, and that can include comfort with technology, of course, sometimes we just can't manage it. And so for immigrant and refugee families, we found that there's that particular barrier with the way that we're approaching things. And we're still trying to work hard to understand that gap. So one of the other pieces I wanted to highlight about what's happening is it's hard for us as organizations to know what's working or not working if we can't see data or see some kind of report on how we're doing. And that's true for most of us. At our hospital, we have data folks who are trying to put reports together on telehealth that will include things like language preference and race, ethnicity, and zip code. So we can watch for disparities as we roll out these telehealth efforts, but it's actually not straightforward. And we've heard about that around the country as people have been wanting race, ethnicity, and language disparities data. And there are articles about that in the national press over the last couple of weeks. It's actually been hard to get for various reasons. At our hospital, it's not hard to get because anyone's trying to hide it or doesn't want to share it. It's just a matter of generating the right ways of pulling the data out so you can see them. But what we have seen as we're waiting for those data is stories being told. And we all know that the stories that we hear usually are more powerful than the graphs or the numbers that we can see. And we know that there are families who are struggling to connect to us through telehealth, specifically because of language or culture. And I'll just give one really quick anecdote. We've been talking with different parents from our advisory board called the Consejo, which is a Spanish language advisory board. And some of the moms have said that they've loved telehealth. It's worked great. They've connected easily. They found it really useful. The language services were great. Whereas another mother has said, it was okay, but I really just want to be in the same room with my doctor. I don't like doing this over a video or over a call. It didn't feel right, and I want to be with the doctor that I really know. And at West, focusing on refugees real briefly, one thing that we know is hard to make work is if you can't get language services linked into your platform confidently for languages of lesser diffusion. For example, among our Burmese refugees that are seen at our West clinic, the language service integration has been really challenging. And so they've ended up only being able to do an audio call instead of video. And they rely on visual cues from their families to see whether the interpretation is working well. And without those visual cues to understand whether this interpretation is good, they said it's almost impossible to have just an audio kind of telehealth visit. And therefore, they're just not able to do those right now. And they're working really hard to change that. But that's an obvious gap where we have families who can access, who speak English or maybe speak Spanish, can access their provider, and then families that are going to have to come in. And so I just wanted to share that even within one organization with different populations, you can see different disparities arise across those languages and cultures. And so finally, across all these other organizations we've been talking to, it's been a scramble. And this may sound familiar to some of you on the webinar today. If you didn't already have telehealth in place before this happened, the organization needed to quickly figure out, where do we get a platform? Do we have to pay for it? Is it private? Can families and individuals actually link in? How do we get language services going? And I won't go on more right now, just in the interest of time, but we'll be happy to share through our question and answer session when we're done with these opening questions about some really innovative ways that people across the country are trying to overcome these issues. But for now, I'll just stop there.
Well, I appreciate you sharing your experience. I know that we have within our network of communities concerned for immigrants and refugees, CSER, it's not just healthcare providers that we have connected to these type of forums and conversations. So I would ask our attendees to find connections with these telehealth providers and telemedicine providers to see how we can implement some of these conversations and other types of services that we're sharing with our family. So if it's a food pantry, what can we learn from the Microsoft Teams, right, is what you all are using over there. And you mentioned the language in Burmese. Yeah. How does that affect other type of service delivery that we're sharing with families?
Absolutely, Celia. And I'll just add real quickly an example of what you're talking about. We've been talking with partners in Seattle who've been working on how to make sure that shelters where there may be women and children who are living because of intimate partner violence, how telehealth or teleconnecting, even if it's not specifically about a health visit, has been brought into centers where they can now do, innovative and creative things to make sure that people are being connected. We know that there's a real issue with a rise in violence in homes as people are sheltering in place. So that's just one example of what you're talking about, where I think lessons can be generalized from one setting into another and can really help connect people.
Yeah, perfect. Thank you. Well, if anyone has questions for Dr. Cowden, please plug them into the chat box. We'll run through those a little bit later, but thank you, Dr. Cowden. We will move on to Gabriela. So Gabriela, I want to make sure you have some time to find your mute button, but I'll start asking the question here. It may seem obvious that a language difference between a healthcare provider or a service provider, the difference between a healthcare or service provider and the person they are supporting might affect telehealth, how it might make telehealth more challenging. So it may seem obvious that a language difference between a healthcare or service provider and the person they are supporting might make telehealth more challenging. But it's not only about language, correct? There are differences in culture that can also affect how successful telehealth is. Can you describe how you've seen both language and culture affect telehealth efforts?
Yes, thank you, Celia. As Dr. Cowden stated, disparities already existed with our immigrant and refugee communities prior to the COVID pandemic. And now what we're finding as interpreters, as language providers, is we're not only dealing with language barriers, cultural barriers, and now with telehealth and telemedicine, technological barriers. And all three of them are sort of integrated and impact each other. And so while we were very fortunate here at TMC because we already had an in-house, very robust language program with our interpreters that already had connections with people in their communities, because our interpreters come from like 15 different countries and they're seen as leaders in their community. We also had great relationships with our providers. And so usually when a new service is implemented, an organization, plans, looks at different populations and tries to, streamline the approach so that it is usable by all the population. I guess what I'm trying to say is that sometimes when you look at a system, a process that will work for an English-speaking population, it doesn't work for the various cultures. And even sometimes a culture within a culture and patient preferences and different things like that. So we had to act very quickly as a hospital system. So right away, we didn't allow visitors. So patients that use their support system, their families, to come in with them into the hospitals couldn't come in. We had to screen people at the door. We had to work quickly to identify these people so that we can get an interpreter to them. It's really sad because right now there are people lying in hospital beds that may not know that they have COVID or why they're there. They don't understand, like elderly people, why their family members won't come and visit them. So quickly as an organization, we instituted different platforms to communicate with our patients, with our LEP patients. So, for example, one of the biggest barriers that we found is downloading the app. And I think this was already mentioned. So what we do, we have to quickly reach out to all our patients as a hospital system, and I'm talking all of our patients, canceling appointments or giving them the option to switch to a telephone visit or a video visit if it was appropriate. So the whole process was the contact center would call the patient ahead of time, give them that option, and then give them instructions to download the app, or simply say, go to this site and download the app so that you can have a video visit with your doctor. So an English-speaking patient would be, great, doctor, got it. Okay, or great, representative, I got it. So I found myself interpreting for some of these sessions for the contact center. And so we'd reach out to the Spanish patient and, interpreters interpret everything that is said exactly as it is said. And the interpretation was, go to your app store and download the app. And so I interpreted that. And the lady said, oh, okay, see. And so I knew it was kind of like a hesitation there. And so I had to step out of my role as interpreter. And I said, Senora, in Spanish, do you know what I mean? Do you know where your app store is and how to download the app? She goes, I know. And so I said, okay, well, how about if after we're done with scheduling your appointment, I'll have one of my navigators or interpreters call you back and teach you how to do it and walk you through it. And she was like so grateful, and she's like, oh, that would be wonderful, thank you. So I guess where this story is going is that what we think works for one population will not work for another. As I mentioned, we do serve the Spanish, Arabic, and Somali community. So what I'm seeing with some of our Arabic patients and our Arabic interpreters are telling us this is that, and I never thought about this. So when we're offering the telephone or the video visit, many of our Arabic women, especially Muslim women, are choosing to go with the telephone visit. And so I asked my Arabic cultural navigators and interpreters, what is going on? And so what they shared with me was that in the Arabic culture, for example, a woman, when she's at home, she doesn't wear her hijab because it's not necessary. And that's the head covering. It's not necessary around their family. And so if they're going to do a video visit, they're going to need to put their hijab on at home, make sure their forehead is covered, their ears, their neck. And then especially if their doctor is a male, they still think it's not appropriate. And so I said, what do you mean? It's a video visit. And so what they told me was that the patients were saying that the perception is that they're too close to a male, even on the screen. And so, but what's the difference when they come into the exam room with the doctor? They're in the same room. And so my interpreter told me, she said, yes, however, the interpreter's there as well, and it's usually a female. And the perception in the room that the doctor is further away, the distance. So even though really the distance is further away when you're on the phone or a video, and that's what they think. So they think it's not appropriate. So that was just one of the stories that they shared with me. The other thing is that many Arabic families have too many people in their home, so there's not a quiet place to go for the video visit to work. So those are just some of the stories I have to share with you. I'm sure we're going to, keep discovering others, and sometimes there are things that we just never think about before we implement systems like this. So we have a few things that we're doing to try to overcome this with patients and families. One example I'd share with you is that sometimes our Latino families, when given the choice, they would say, oh, no, thank you. I'll just wait till afterwards when it's okay to come to the hospital because I want to see my doctor. And so sort of what we did was make it okay for them to do a video visit or a phone consult. We would tell them, hey, I tried it, in Spanish in their language, and they trusted us. And we said, and the visit went really well. I got to talk to my doctor. I got to ask him all the questions. And so then we would say, you know what, I'll help you download the app. I'll teach you how to do it. And then when the doctor calls you, I will be right there with him on the video call, and it'll be okay. And so then it went from absolutely not to, okay, I want to try it. And so in a sense, we held their hand, we made it okay. Then the patient saw that it was wonderful, it worked out great, they loved it. Then they tell their neighbor, and they tell, their other family member. And so now it's becoming more and more popular with our Spanish-speaking community if they have the capability of downloading the app and all of that. One other barrier that I found, and I don't know if you would consider it maybe socioeconomic, and I know it's not only for immigrants and refugees, is that many of our patients, because we do serve a vulnerable patient population, they do not have access to smartphones. So many of them have government-issued phones. And what my interpreters are telling me is that they're those like older I think they said Nokia phones that has a very small screen. So it's not even possible to do a video call. So now we're talking about, what do we do for that population? I heard a lot of information. Like, we're trying to capture this data. So our interpreters do document in the medical record. We have a very sophisticated platform, and we're trying to find ways to document this information so we can stratify it and pull that data to figure out what it is we need to do to make sure that we're not creating more disparities as we continue on using telemedicine.
Well, Gabrielle, my mind is running all sorts of ways, but because you covered a lot and I love it all. One of the things that you mentioned early on was that you had to reach out to all of your patients quickly and immediately. I would say that I'm familiar with, and many others may be as well, disconnected phone numbers, incorrect addresses. How did that work for you? As far as, I have to say, I'm pretty impressed if your administration was able and leadership was able to move pretty quickly, and you've gone through all of these ups and downs in such a short period of time. You all moved very quickly and responded, as best you could. But what was it like to say, all right, everyone, let's reach all of our patients? Because we know of phone number issues, and now you mentioned, the government issued phones, and how was that experience?
Okay, so as I explained, we're very fortunate. It was really like, I've been here at Truman Medical Center since 2010. It was really, we had laid the groundwork, the foundation for making this quick transition possible. So we were very lucky. We had an existing program of interpreters and cultural health navigators with connections to the community. Our leadership really believed in us and respected us. And it was probably about 6 years ago, we developed this great new tool, and it's very automated. So anytime a patient walks through our door, our doctors can order, just like they order an x-ray, they can order an interpreter. And all of our interpreter we have the technology, I guess is what I'm saying. So they all carry tablets, and as soon as the order is placed, it just fires an order to a task list, and we can see enterprise-wide where our patients are, what language they need, if the doctor needs it for consent, if it's for a surgery, if it's physical therapy, whatever it is, labor. So our interpreters can be anywhere. Right now, half of our interpreters are at home, and some are here in the office because of the need to social distance. So we can see the order, we can triage our request, and then we self-dispatch. Like, no one has to tell us where to go. The doctor puts in their number, they put in the request that they need a site call or a video visit, if it's going to be a phone visit. And then, so I will just assign myself, for example, if I'm the interpreter, I'll call up the doctor and I'll make it happen. I'll call the patient. So then the other thing that we do is we chart in the medical record. And we have a very sophisticated dashboard as interpreters, so we can pull the data and see, how many interpretations or how many patients speak Spanish, how many are Arabic, how many are Somali. And so that's one part. And so I can pull it, I can pull their phone numbers, I can pull their addresses, I can pull the last time they were here. And so the other thing I will say is that we have the cultural health navigators who already have these connections with the communities. For example, Somali and the Arabic community, they communicate with each other even outside the hospital. So many of them, and what we found along the years, and we know this, is that when a registration rep asks a Somali patient for a phone number, they may give their neighbor's phone number because their neighbor speaks English. The same holds true for the Arabic or Somali. So since the interpreters are now able to document in the medical record, so we chart just like professionals, our patients will tell us their real phone number. So over the years, we're working on updating the medical record to their real phone number. So prior to us being able to chart the medical record, we just kept a list of the real phone numbers. I know this sounds silly, but it's really true because it's what's happening. If someone calls a patient at home, they can't answer, they don't understand. So that's their way of getting their message to them. So now with the problem with social isolation and they can't even go see their neighbors because they're afraid to go outside, the message is not coming through. So we've developed these relationships. Our patients are reaching out to my interpreters and navigators via FaceTime, WhatsApp, and or WhatsApp, I believe it's called. And so we're making it okay for them to reach us. So I asked my team of interpreters, how are we going to make this happen? How are we going to reach our patients? We need to do some type of, initiative to help them download this app and teach them about telemedicine. And so very quickly, they're a wonderful team. I can't say enough about empowering your employees to make decisions and make it okay. So we just printed a whole list of all the patients that we've seen within the last 6 months. And this is thousands of patients, especially for the Spanish community. And so we're just printing our list of appointments for the next day. And then we are sharing a spreadsheet, and we're reaching out to the patients and teaching them how to download the app and telling them that, okay, tomorrow your appointment's at 2 o'clock. Be on the lookout for a text from your doctor. So when you get that text, click on it. So we're walking them through the whole process. And so our goal is to reach every single patient that we've had contact with, to teach them how to download the app and then show them what telemedicine is all about. And so we're capturing that data so we know which patients can do it, which ones cannot. Trying to get very creative to be able to do that.
That's awesome. I think that with you all collecting that data, it's not like the patient has to hear 3 times from the next 3 receptionists, can you download, because you already had it documented there. So I love hearing that. Are there any, and I think you shared a lot of really good practical information, having that foundation of support, empowering your employees, and these specific strategies that you've taken out there. Are there any other lessons that you would like to share with the group on how to support immigrants and refugees during this telehealth era?
We have so many ideas. Well, one thing that we are doing, we're working with our public relations department to create very short, like educational videos. So we found that one thing that many hospital systems or clinics were doing, their idea of doing outreach in the community was to translate a bunch of material. So we've gotten multiple requests. Can you translate this? Can you translate that? We need it in Arabic. We need it in Somali. We need it in Spanish. And so we would get the material, and the literacy level was just not appropriate, in my opinion, especially for our immigrant and refugee community. It's like we need to leave them with just the basic things, like what they really need to know. And there's so much that's lost in translation. For example, social distancing. What does that mean? It means different things to different people. Flatten the curve. What does that mean? And how do you translate that? And it just isn't enough. So we would give them their discharge instructions, but it was like many pages of written material. And yes, maybe it was written in Spanish, but I honestly, there's just so much going on right now that I probably wouldn't even read it. So hospital systems are struggling, especially those that don't have an existing language department that could reach out and explain verbally to our patients. So one of the ideas that came from our team was to create these small little videos that we can just do and send. And one example is the app. So we filmed one of my interpreters downloading the app on his phone, and he's walking the patient through it, like speaking in Spanish, as he does every single step. And so that's created as a little link. Now that one was not done professionally, but we can send that to our patients as a link, and then they can just click on it and watch how to do it. For our Arabic population, we created like pictures of what it looks like on the phone, on your smartphone when you download the app. Because if you think about it, Arabic and even the English alphabet is very different. So what they're doing is even if they're letters and the letters say site call or whatever the application is, we have to teach people to recognize what it looks like. So they're just kind of comparing symbols or a picture. So we're just doing some little things like that we're hoping will have a big impact on patients' ability to use telemedicine. And we're trying to track this by hopefully seeing an upward trend on like a decrease in no-show rate, even for televideo appointments. So that's some of what we're doing, but I'll keep you all posted if my team comes up with any other innovative ideas.
Wow. Well, I appreciate you sharing that those lessons with us. And if any of you have any questions for Gabriela, please feel free to plug them into the chat box. We'll get back and get some more questions to you, Gabriela, in just a bit. But Dr. Chelsea, we'll move on to you a little bit. You have worked in telehealth services for years and have been an advocate for populations that are harder to reach. For those of us supporting immigrant and refugees, what are the key issues that you have seen related to telehealth from the technology side, including the choice of platform, determining what type of visits work for telehealth, the including of interpreters in a visit, and connectivity? So like in rural areas or even in urban areas where internet connection isn't well.
Wow, thank you. That is a lot for me to digest. I'm going to try and take them one by one and see if I don't squirrel and go off on a tangent. I see the key issues for trying to reach a more vulnerable population with a new technology is going to be communication. It either is going to make it better or be a barrier for any population, including those that are tech savvy will probably be better. For those that technology is not something they're comfortable with or they don't have access to, it could be a barrier. And the difference is how we are going to implement, how we are going to be thoughtful and mindful and including such things as bringing in the people such as Iran to say what works for you, what are barriers, how would you like to receive the information, how would you like to meet with your provider. This is a place where the communication is going to be a make it or break it for a lot of people. The second is going to be continuity of care. We already recognize that immigrant and refugee populations receive inequitable health care for a number of reasons. Telemedicine or telehealth can make the difference between making it better or being a barrier, because we can eliminate a lot of barriers and have more frequent visits because it's more convenient for the families where they don't have to take off from work or get transportation or find someone to take care of the kids. All of these can be removed with telehealth, but now you've got to figure out how you're going to get them connected and to want to do this visit, which brings me to the last is confidence. And I think Gabriela touched on this a lot, and so did JC, that they need to have a trusted individual, usually somebody that's culturally similar to them, to reach out and be the face, be the voice of somebody that says, I connect with you, I understand where you're coming from, and let me help you through this process. Let me walk you through this journey. It's scary, it's different, it's unknown, but we can make this happen, and we can connect you with a caring provider that wants to give, in our case, your child the best care possible. And we could have more frequent visits with telemedicine for those patients that may be medically complex, where they may have diabetes and need to have regular check-ins. We can have a lot of folks that are receiving remote patient monitoring with their diabetes control or with their heart rate and blood pressure, so that the physician can have real-time or store and forward or asynchronous way of providing telehealth to see what all that data is and be more closely connected with the patients. So if we don't offer those, that could be a barrier. If we don't teach them how to connect with it, that could be a barrier. The choice of a platform for any organization has got to be deliberate and thoughtful, because the one the clinic down the street is using and loves may not be the right one for you and your organization. Your colleagues at the other university that's using this particular platform may love it, and it's not going to work for you for other reasons. You really need to know what you want to get out of your platform. You want to know, what kind of finances can you put into it? What money do you have for capital expenses for the equipment and the software, and the technical support and the people that you need to run it? Do you need a low cost alternative that you can just pick up and go and start with? Connectivity with your families to know, is this going to be something that they have to download an app for? Is it something that they can just type in and see a website in order to access? There are a lot of different ways that you can do telemedicine, and there's a lot of difference in what they offer. Can they integrate into your electronic health record? And do you want to spend the time and money to do that, or is that even necessary for your group? Is that a wish list, or is that really a need? All of these things need to be taken into consideration as you're choosing them, because with a lot of organizations that ended up with their electronic health record, if they didn't make a good choice up front, they were stuck with that electronic health record and invested a lot of money and time and resources. And some of them changed, completely uphauled their electronic health system to something different. So it's good to make a thoughtful choice up front. You had touched on the next point. I can't remember your next point in your questions after the platform.
Yeah, so what type of visits do work for telehealth? So yeah, thoughts.
Definitely visits where you're going to communicate information to families. If you've got a lab results that you want to discuss with them, that's an ideal visit. If you need a prescription fill, that's an ideal visit. If you have patients that don't need an in-depth physical exam, if it's something like a rash, if it's something that is easy to see, like he hurt his leg and he's got a bruise, those can be pretty straightforward. We see a lot of urgent care telemedicine for such things like pink eye and colds and vomiting and diarrhea symptoms, where you can get very creative with how you can complete your exam through a video visit. Telebehavioral therapy is particularly important to do behavioral health medicine or telepsychiatry. There's now teledentistry, which does a lot more education and help with pain management for those that are having tooth pain, and connecting them with an appropriate dentist, which isn't urgent or emergent, but in the moment, the family wants some reassurance and some immediate supportive cares to help out. It's also, if you're traveling and you don't have access to your provider because you're out of state or out of country, telehealth can be very important so that you can stay connected with your medical home. If you want to see your doctor, but you've got 6 kids and you've got little ones and you don't want to take them into the emergency department and your doctor's office is closed, that's a good time to do telemedicine. And we've had a lot of families have been very grateful to not have to take their kids in to an urgent care or emergency department visit when they just have one sick kid that they need care for. If you need access to a specialist that's not in your area, a lot of consultation telemedicine can be done that way. And that's originally how a lot of telemedicine started, was allowing folks that are in rural areas to connect with specialists or doctors that are not in their area. But now we can offer that to people across the board in other states to want to see a specific subspecialist in an area that they don't have in their state. All of these could be ideal. Those visits that are not ideal are those that need urgent or emergent care, that need an in-person exam because of a complex symptoms or concerns for dehydration. If the family is not interested in a telehealth visit, it's probably not ideal for a telehealth visit. And if they don't have access to the equipment or the internet that they need to do a telehealth visit, it's important to find that out up front before offering the visit, that they have the ability to have a telehealth visit.
Thank you. Thank you for that, for those thoughts. You mentioned, and I'm thinking about the electronic health systems or the records. You know, if you started off and you made a good choice and you have everything that you need, well, what happens from here forward? So let's say, what is the future of telehealth in both short-term, long-term over the next, I mean, we're still, you know, under certain stay-at-home orders. So short-term and long-term, what does the future of telehealth look like? And is there any policy or advocacy that we should be paying attention to?
Well, I will say that one of the best things that ever came out of the COVID pandemic is the implementation of telemedicine throughout the world and within our local city. It was predicted that medical visits would be via telemedicine by 2050, 2030. And right now in 2020, over 50% of physicians are doing telemedicine visits. So we've already met that prediction. And this is a great catalyst going forward for implementing the opportunities for what we can do to innovate the way we deliver healthcare. We now recognize that geography is no longer has to be a boundary. Having a plethora of subspecialists in your area isn't necessary to get high quality care. That you don't have to go in to see your doctor every month for important checkups because we can do remote patient monitoring. It's also been mentioned about sending out more digital health technology by sending out texts and sending out videos, such as post-surgery discharge and you need to do wound care on yourself or do dressing changes. And for day one, there is a video that gets sent to you that says, this is what your wound should look like, and this is how you're going to redress the wound. Second video that pops out to you that says, this is kind of how it should look on day two. This is what we're going to be doing on day two. Instead of reading all of those instructions, particularly if they're in a different language and we are not completely convinced that the translation is going to be ideal, that at least you can show and provide a better venue for conveying the communication that you need. I can go on and on about all the great benefits that are there. The only thing that's going to limit us is our creativity and our willingness to innovate and do something different from what we've been doing, because we've got a lot of people that have some great ideas, as we've seen in this COVID crisis, with what people have been able to come up with to deal with limited access to supplies. And so I think we can do the same thing in telemedicine. If we have limited access to the smartphones or the laptop, we can now consider how we're going to get around that and not make it a barrier, but make it better. And we just put in for an FCC grant at Children's Mercy so that we can continue our telemedicine direction and vision and provide more remote monitoring devices so those chronic complex kids can have exams within the home with a device that the doctor can see and the family can see from at home, including an otoscope so they can look in the ears, a lighted tongue depressor so that the physician can see in the mouth, and a stethoscope that connects to the device so the physician can hear and lungs and heart exam, which will prevent them from having to come in for frequent in-person visits, because if you're hooked up to a lot of tubes and wires and machines, it's really difficult for parents to transport these really complex kids. And if they can get that care without having to leave the home, that is great. This is also a place where we can really focus on the vulnerable populations, such as our immigrant and refugee populations, and figure out what is needed to provide care to them in the home without making them come out and see us. Because I think that we can do some extraordinary care with these new care delivery models. We just need the people to come up with the ideas and our leadership to trust in our ability to want to serve and to do something different and meet these patients where they are.
I was taking myself off mute, but I think that's, if that's okay, I think that's a perfect way to kind of end your segment there. Having the call for leadership, creativity, innovation, you know, on all of our part is absolutely necessary because we're all into this new digital territory as well. I say because I posted in the chat box there. I should have mentioned, please post your questions in the Q&A box. So I'm learning this technology, and so many of us will continue to learn this platform and other platforms. So creativity, and I don't know if we've mentioned this before, but patience. I think some of those just simple qualities are necessary during this period. Patience with ourselves and patience with others. So I think patient is kind of a good way to move on to our next segment. So we have Iran with us, who is a chef, as you mentioned earlier, here in Kansas City. And I think it's, I really don't say this lightly, to have a patient share their personal experience on what telehealth looks like during this period. We thank you for joining us. So Iran, I'll let you start unmuting yourself while I get my question ready. But I know that you recently had your first telehealth appointment. Can you walk us through and tell us what it was like, how it was set up, what did it look like? Just what was your telehealth appointment like?
They call me and they tell me that I cannot go to the office because the COVID, and they tell me I can reschedule my appointment, or I can do it over the over to the computer. And I said, okay, that's fine. And so they have me download an app. They called me like 5 days before my appointment, and I told them, okay, I do the video call, the video appointment. And so they tell me I need to download the app, and we can, and when I download the app, I can do like a test, like a trial. So I don't have issues the day of the appointment. But I already have downloaded the app before they told me to. And honestly, I'm not very good with technology. So I have to look in the internet, like how to download it, how to set it up and everything. And I struggled for a little bit, but I did okay. But that was like a week before my appointment. So the lady sent me this link, and I log into my app, and I went to the link, and I do the test before that morning, like a couple hours before my appointment. So, I mean, at the time I didn't have any problems. I log in fine and everything. But when I have the actual appointment is when I have the problems. Like I was in, like when we started the appointment, I was having the connectivity wasn't working for her on her side, and like I can see her but I can hear her, and then it keeps like the image keep going in and out. We just do like a Facebook call. She asked for my permit, and I said it's fine. So we did FaceTime.
Okay, so then if I understand this correctly, and this is a lesson for all of us, that's where I'm trying to pull from this, is that there can be an app, you can download it, you can log in, but then you end up using your cell phone with FaceTime.
Yeah. Yeah, because she was having problems, not me. But you know, at first it was I was a little, honestly, I was like nervous because I was thinking like like how bad if she doesn't understand what I'm saying, or you know. I don't know, I was a little worried about wasn't able to have a successful appointment.
But after it was over, do you think that you got what you wanted from that appointment?
Um, Not really, because well, maybe that's gonna work fine for other patients, but in my case, I have a diabetic, so every time I go to the doctor, I always want to see like has my liver, has my cholesterol, has my AC1, where they told you your glucose. How do you say? You
Yeah,
AC1.
A1C.
They want to see. Yeah, and well, none of that stuff it was done. So I was like, I don't know. I don't honestly, in my personal case, I didn't think it was very helpful.
Well, I appreciate you sharing that experience with us. I would like to know what your thoughts are. How do you think other immigrants or refugees might do with these telehealth appointments? So you said that you're not the best at technology, but you were still able to download and you have FaceTime. What challenges do you see for others that might not have the access you have?
Well, what it's simple. Thinking of my mom. Her English is very limited. Um, she doesn't know like she know little things that we taught her like how to text, how to look for stuff in YouTube. Like really simple stuff. Um, and I think like in her case, it would be like no, it would be like super hard. She would have to have like someone like probably me or somebody with more knowledge, to help her download the app. Um, and she have another barrier too. She doesn't have like a smartphone. She does have a smartphone, but it's one of those really crappy ones. It's really hard. Like I can't even make a video call through a WhatsApp with her because it's always failing. You know. So I think that's a bit like the language is a barrier. The lack of having technology like internet, or like a good phone that is gonna work. She doesn't have a laptop too. So I don't know. I think for people like my mom, it's not gonna work. Like younger people like me, with like I think my English is pretty okay, but as people my age that I know that they have to go to their appointments with somebody else to translate for them, or they had to ask for someone to translate. So do that. So like if you want to have a appointment through the cell phone, through through the internet, I mean, they had to make sure they had someone there to translate for them or help them get set up. Like I mean, I don't and especially for people with a low income, like people that doesn't make good money, it's gonna be really hard because they had to find the resources like the phone. They had to go probably to a place where they can borrow a laptop or things like that.
Well, I appreciate that feedback, because earlier we were talking about how telehealth, we will see it more, and or hospitals or clinics and even other places. So we said this is not just medical. You could have food pantries and Catholic charities and community organizations. What do you think clinics and hospitals and anyone else who's trying to reach families that speak other languages other than English, so immigrants and refugees, what do they need to do in order for more immigrants and refugees to feel comfortable with this type of communication online? So what do they need to do?
First of all, don't put them in the spot. Like tell them like make sure you tell them before their appointment so they can get like ready, because I feel like they put me on the spot, I knew I kind of knew it was coming, but I wasn't sure how it was going to work. And I feel like they put me on the spot. They're like, okay, you want to do this through the internet, or we can set up your appointment for 3 more months, ahead of time. And I'm like, well, right now, especially with all this COVID stuff going on, I want to make sure I'm okay, I'm in a good shape, in case I get infected. So I'm like, no, I want to have my appointment. So I feel like the pressure to do it, So I think it'll be good if they tell them before it's going to happen, like even like a couple weeks ahead of time, so they can get prepared. If they don't have a good phone, maybe they can get a better phone. So things like that, just make sure they tell them ahead of time. There's one. And the other thing, maybe walking through, like helping, like making sure they be able to do whatever they need, like download the app or log in, something so simple like log in. Some people will have trouble with it. I got to log in for my mom's account in the bank all the time for her because she doesn't know how, something really simple like that. So just make sure they know how to use the technology. Once they have it, make sure they have like some kind of, training, like walk them through, just, hey, you're going to do this and then, whatever. Because, like older people, you have to like teaching how to do things, It's not like, new generations, you just got to verbally tell them, you just go here, do this, click there, But older people is different. You got to like walk them through, And I would say just give him a time, give him a heads up, like a good 2 weeks, find out first if they have the whatever they need, the equipment, like the computer, the phone. Make sure they have internet in the house. I don't know, because this is the things that people probably don't think about, They're like, oh, you want to have a visit over your phone? Oh yeah, sure, But then when they actually gonna have the appointment, they're gonna find out all the barriers they have.
Well, I appreciate you mentioning the password, because I just had a quick thought. So many of us were used to creating our passwords with the uppercase and the lowercase and the special symbol and et cetera and whatever. If someone's being asked to create a secure password for this specific downloaded app, maybe that 4-letter, 6-letter word that people normally use is not going to work on that. So then what happens when you have to log in that second or third or that 5th time to your telehealth appointment? So yeah, I appreciate you mentioning that. Iran, is there anything else you would like to share with us before we kind of move on to some questions from the attendees?
No, looks like, I'm listening what you guys saying, and looks like you guys have a pretty good knowledge of what you guys doing. Well, like Gabrielle says, every culture is different, and what is normal for me is not gonna be for one of you guys, and the other way around, just be patient, just be patient, because you're gonna run into all kinds of people, people that's gonna be willing to do whatever it takes to get their appointment, and you're gonna find people that like grumpy old people, that they're gonna get mad, they're gonna be frustrated, but they don't mean it. It's just they're being, they get frustrated, but it probably is gonna work, honestly. In my case, I feel like it didn't work, but that doesn't mean anything, that just means that it didn't work for me, but I'm pretty sure you guys will find out like ways to make it work, to make it better, like I was telling you, maybe if they would have sent me something to my home to send tests, like you know, like my glucose readings before ahead of time. So when we have the appointment, the doctors know my numbers, you know, or like urine, you know, and I can send it back so she knows my cholesterol or whatever they check is good, you know, things like that. Probably that will make me feel more like my appointment was successful, you know. But I'm pretty sure you guys will figure everything out.
Well, thank you, Iram. I think you'll have quite a task because yes, we will make this better. So thank you so much. So if you can still hang around a little bit, we'll go through some questions. Andrea, I will let you kind of take over this piece. I know that you've been juggling the Q&A and the chat box. So we'll try to answer as many as we can, but I'll let you take it from here.
Yes, absolutely. And I just saw a comment from one of the attendees that was thanking you, Iran, for sharing your perspective and helping us as providers to keep certain things in mind when we're trying to reach out to our immigrant and refugee families. So thank you to you, Iran, and all the panelists. So we have been getting some questions in, so I'm going to go through those and put them out to the panelists. Our first one is from Francisco Martinez. His question says, one of the greatest lessons COVID has hopefully taught us is that it is really important to push for professional humility, health literacy, and simple language to empower all patients and attain better health outcomes. The question is, what are we going to do together, all healthcare organizations, large or small, in a common front to continually teach and apply these principles in our everyday healthcare practice? I don't know who would like to start.
Hey, this is JC. I know Francisco quite well. Thank you for that question that there's no way we can possibly answer completely today, but it is the key question, right? That underlies not only what we're trying to achieve through telehealth and make sure we're not leaving families behind, but for every family we ever see. What you've laid out in your opening statement is what we're trying to achieve, what we have to achieve. But a couple of quick thoughts about what do we really do. I think there are local level things to do within our organizations, which may not seem very powerful, but they grow in their power, is saying things like you said in your question, saying that out loud in meetings, talking about other people, with other people about forming groups within your organization to say, these are things that aren't extra or bonuses. These have to underlie all the work we do. And saying these things over and over again, and especially with leaders, can start to create momentum within an organization. So that's really key. But when we get out of organizations into the community, policy it rules, right? I mean, literally. And when we talk about what's reimbursed by insurance companies, for example, that will drive our momentum in healthcare either towards or away from what you've laid out as the vision. And so when we get familiar with advocacy and policy and how things that might feel annoying to try to understand, which has to do with what happens on certain Capitol Hills and who the representatives are and what they stand for, we have to be involved in that because that's what really drives at a large level what's going to happen. I saw a question that I think we're going to get to about incentivizing hospitals, incentivizing different people to make sure we include all people and families. And a lot of those incentives are just straight up money. It comes through reimbursement and billing and grant funding and technologies that are or are not paid for. So anyway, I just wanted to comment on that idea of the very local things any of us can do today, which has to do with conversations and creating momentum, but also those really big things that I have to remind myself not to hide from. Get out there and try to understand the policy that's going on, both locally and nationally. Or all those smaller conversations won't necessarily lead to those big changes we want to see.
Perfect. Thank you, Dr. Cowden. Anybody else want to add anything? All right, we'll move into the next question. This is more, and I think from a community perspective, what more can others in the community, and including CanCare, the MCOs, do to support and promote telemedicine, telehealth at the immigrant refugee community level? For example, some ideas are maybe providing internet-capable tablets to their clients, provide training and support with the app in their language.
Well, I'll jump in a little bit, and I might not have the best answer, but again, my name is Celia with United Healthcare, one of the CanCare, the Medicaid health plans. You know, we've had this conversation too. It was a couple of weeks ago where we were talking about, you know, how can we improve the, internet access. And one of some of the ideas that we were working around was like, you know, how can we keep doing the resource and referral to the internet program? So we try to stay involved. You know, what is Comcast providing? What is Spectrum providing? You know, the 3 months, the no pay, the et cetera. So can we, you know, make sure that we're connected to the existing programs, you know, refer our families, connecting as much as we can to the existing programs, one. And then with one of our colleagues that we have out in Great Bend and Salina, she was like, that means nothing out here. And we're like, okay, so even if we were able to, you know, maybe collaborate with some partners, bring in some resources, and I'm not making any promises, but even if we were to collect some tangible pieces, there isn't a satellite tower that will connect, you know, give them that internet connectivity. So I will say that, you know, we've run into that challenge as well to say, what is existing? You know, and even when we mention rural, it's still urban. I live here on the Missouri side. You can go off of 23rd and Van Brunt, and there is no internet connection. So I'm sorry that's not an answer. I know that for the, you know, immediate part, we do try to look to other partners and say, what is happening? How can we support? And, you know, to the previous question, what are those collaborative efforts? You know, I'll give a little shout out to, you know, our Kansas City mayor yesterday in one of his, in his press conference, where he said early on, all of these 4 counties came together and we collaborated very well. Now we're at a different stage. How can we work together? And I would be interested in seeing how all of our partners, you know, CCI, you know, CSER, people in the chat, you know, how do we really continue conversations outside of this webinar to have true long-term, you know, relationships and collaborations? That's why we're glad to be a part of this conversation, but I'm sorry I don't have a better answer. We tried to see what is existing and how to support from there.
I think you bring up some good points, Celia. Go ahead, Dr. Cowden.
Sorry, Chelsea, it looks like you came off of mute there. Do you want to?
Oh, I would just add a little bit to that too, that, you know, Children's Mercy Hospital has our patient care network where we take financial risk for 125,000 Medicaid patients. And that is where our telemedicine program started outside of our multi-specialty facilitated visits, is to provide those urgent care after hours for that patient population. And we had very low uptick in the first few years, not because likely our marketing strategy probably wasn't ideal. We were not marketing throughout the hospital. We were only sending out letters from the primary care practices advertising this was a free covered service for their Medicaid program. And many times if they get a letter from Children's Mercy or from their doctor's office, they may not open it. It may have been a bill that they didn't want to deal with. They may no longer be living at that address, may not have been the right address. And it's not been shown to be the best way to reach people when it comes to marketing and making announcements. So more recently, we have Children's Mercy now has a web page that has a link to our website and how to download the app there. But also we are using a lot of our non-medical professionals, our case managers that go out to the various clinics to provide the flyer, to announce it for those in the waiting room or after their visit, to show them how to download the app and do it for them, or to show them where to go on the website so they can just click on the link to access the telemedicine platform. And trying to go to where the families are, I guess, has been my biggest learning experience from this. Is if they're showing up in the emergency department, go meet them in the emergency department. If they're showing up at their doctor's office, then go meet them at their doctor's office and have that in-person connection, because that's where you're going to gain the confidence, the trust, and the understanding that this person is reaching out one-on-one, face-to-face. They're going to walk me through it. They're going to show it to me. I'm going to understand it. So the next time you do have a video visit, that it's not quite as scary. But I think, and it's important that we don't wait for patients to come to us, that we need to go to where the patients are and figure out what the barriers are. Within this FCC grant, we did request several hundred devices that can be in the home. We requested the Tyco Care devices from that company, having a little bit of experience with it, as well as little personal hotspots that we can give to those families that don't have good internet access, that are just used so that they can complete a telemedicine visit. It doesn't need to be used for anything else in the home. But for those families that really need the access and just don't have the ability to get it, if the hospital provides it or the healthcare program provides it, that is going to keep them connected and continue the continuity of care and the communication. I don't have anything to disclose, and I don't push any brands. I do recognize that Best Buy is attempting to rebrand themselves as a place for medical devices. So if you're interested in maybe seeing what's out there, Best Buy is becoming kind of that warehouse of where you can get these peripheral devices or things to connect people, patients with their healthcare provider, and various types of things such as remote monitoring and such. That might be a place to go look. Thank you.
Perfect.
I was just going to jump in real quick. Chelsea, it's funny you mentioned Best Buy. You know, there's been this movement, very successful movement, to have cultural navigators start to be part of the way that we work and partner with families and patients. And Gabriella has a lot of experience with that and talked about that. And we've seen that in different parts of the country. But what we're hearing about, and what I hear creative people talking about, is how we combine the idea of cultural navigation around health and healthcare with that geek squad kind of approach of that navigator, technological navigator, right? Someone, and you've talked about it, and others in this call have talked about it, is, and Iran talked about this, is have the person who can actually sit there and just do it with you and show you how to do it. So rather than just sending you a flyer that has printed words on it that you might not be able to read well or understand, someone just does it with you. And so having that combination of that cultural navigation, language navigation, and technological know-how to kind of work through those pieces that are going to be new for a lot of people is something we would like to see emerge as something that becomes more of a standard of care. When we're going to connect folks, that's one of the options, is someone just works with you directly, goes to your house and does it. Can't do that with social distancing very well, but in future, it would be nice to see that become a regular part of our standard approach.
Thank you, Dr. Cowden and Dr. Johnson, Celia, for helping to answer that question. Our next question is, we have many safety net patients get their medicines provided using the patient assistant programs, or otherwise known as PAP, from pharmaceutical manufacturers. Many require patient and doctors to sign the paper application. Does anyone have a solution for how to do PAP when we are all telecommuting?
Well, the
I'll
idea, oh, go ahead, Doc.
Go ahead, Chelsea.
I went first last time. Go for it. You probably say what I was going to say anyway.
Yeah, we may have the same things to offer. One thing, this is not easy for a family to do, but it's something that a case manager, a care coordinator, a physician, a nurse, someone who's working with a family could do, is to contact the pharmaceutical company who's providing that assistance and ask them if an electronic signature would be allowed. And so if it is allowed, that doesn't make it suddenly really easy to do, but at least then you know that you could walk someone through kind of signing something through a screen potentially. And I know that's not going to work all the time. If the pharmaceutical company were to say that's not acceptable, then of course you're left with either having a courier that would actually be able to deliver the paperwork back and forth, or using a snail mail, old-fashioned snail mail. So with enough advance notice, any of those things could work. When it's more urgent, then things could get very stressful when you're trying to figure out how to get these important documents signed. And that's where hopefully the electronic signature could potentially work.
I will take it even a step farther, as we need to continue pushing organizations like the pharmaceutical companies to transition from paper consents to electronic consent forms. We've done that within our organization to send out electronic consents for telemedicine and for medical consent to treat, as well as access to the patient portal. Since we are kind of developing so much digitally and online, that we should be converting a lot of our paper trail into digital signatures and digital consents and paperwork, fillable PDFs that can be electronically signed. These are all tools that have been readily available to us for a number of years now. It's just now time to use them in some newer ways, including setting up these platforms in such a way that it's more convenient if we're not being able to print or scan or do this in person. Thank you. Our next question is, how has telehealth impacted how hospitals assist with sexual assault? Does anybody have any ideas on this? I can only speak for Children's Mercy that currently telehealth is not being utilized with any of our sexual assaults examinations. One of the drawbacks is that there is an implicit knowledge that when we're doing telehealth visits, these are not going to be recorded, and there's privacy issues with not knowing who's going to be in the room, you know, when the physician's on the other side. A lot of these need to be videotaped or taking photos, and we have not gotten to that place where we have been able to take in that collection of all that goes into one of these visits and how to implement something like telemedicine in a legally private and safe way for our patient population. I don't know if others have taken that same approach, but it hasn't been an area that we've touched on yet. Dr. Cowden, do you have anything else to add to that?
No, I don't. I haven't heard anything from our national group who's been together specifically around telehealth and a sexual assault exam, for example, or visit.
Okay, thank you. And then Dr. Johnson, that kind of ties in nicely to another question that we had as far as serving refugees that have experienced trauma and immigrants as well, but this is specific to the refugee community. There's some concern about the fear of being recorded or if their session is going to be interfered with by other entities. Any ideas about just more generally working with individuals that have experienced trauma and some considerations that we may need to take into account? Yes, it is. We don't record telemedicine visits. And if for some reason there were photos that we're going to be taking, or there would need to be some discussion about that at the beginning and some permission that was provided. And you definitely would want to get that permission in writing, as we get permission to use telehealth services and to medically treat. We get electronic consents for that. It is important to be sensitive to that individual who is already traumatized, that this experience of having a video call with someone that you don't know very well, being able to make a connection to provide care with empathy and to have a very good webside manner or telepresence so that you can connect with that person on the other side, which has everything to do with being able to look into the camera and make eye contact as you would, looking like you're looking at the person, but you're really looking at a camera, which can be discombobulating for people that don't do this regularly. To make sure that you've introduced everybody that's in the room with you, whether they can be seen on camera or not,
and to inquire who is all in the room with the patient, and to recognize who they are to the patient, give them an opportunity. If there are other people in the room, do they want them in the room, or is this a good time to have them leave the room for either, you know, a private conversation? Making sure that if you're going to touch on sensitive materials, that you kind of lead into it. So if they do want people to leave the room at that time, they have the opportunity to do that. At this point, we don't recommend full examinations where anybody's going to get undressed. If that is the case, then we would convert that to an in-person exam. We haven't yet reached that place where there is a comfort level patient side where having a visit where you are doing full examinations of those bathing suit areas is an area we're comfortable with at this point. And the concern of being recorded or photos taken just adds to that concern. So although it is not something that professionally we would do, is to record a visit, but even if photos were going to be taken, they should always be done with explicit and written permission, ideally.
Thank you, Dr.
Andrea,
Johnson.
can I share something real quick from the chat line? It came in earlier when we were giving our sort of earlier answers is on the webinar from Charlottesville, the Sexual Assault Resource Agency in Charlottesville, Virginia. And they mentioned that while some platforms like Zoom might be HIPAA compliant, they may not be VAWA compliant, which is Violence Against Women Act, which has its own compliance requirements. So the person mentions using a different platform called CYPH, C-Y-P-H, to meet with clients. And it's one where you don't need to download an app. You can just send them an email or a text with a link. They can get connected immediately. And so it looks like they were just sharing that experience, that they've been able to connect specifically around sexual assault resource agency work. So I felt like that tied in with the question around telehealth and sexual assault, some practical advice there.
Sure, that was great addition. Thank you, Dr. Cowden. And Dr. Johnson, thank you for sharing those tangible things that we need to keep in mind in order to create a safe space for the patients on the other end, and things that providers can do to help to create that safe space. So I appreciate you sharing that. And I also just learned a new terminology, webside manner. That is great. We have to evolve our terms with the technology as well. So our next question we have here from Isabel. What happens if the person doesn't have health insurance? Do all of the health insurances cover telehealth services?
So I'm not an expert, but on the CanCare side, and someone will correct me, but I think so KDHE extended there's an end date, right, where those telehealth appointments are those acceptable codes. So I'd say from the CanCare side, I know that there's been adjustments made by the state to get those covered. I won't speak for uninsured.
So I know for me, I work at Vibrant Health, and we offer right now our telemedicine, teletherapy, and all of those are for those that are insured, but then we also do offer our sliding fee scale for those that are uninsured as well. So I think several places are offering the sliding fee for uninsured folks. All right, our next question.
Sorry, Andrea, I just want to I'll just throw in real quick that talking to folks around the country, these policies that are known as telehealth parity laws or parity policies address whether or not within that state insurers are required to cover services that they would cover in person by telehealth. The interesting piece to be aware of for anyone out there working in your own organization, either Kansas or Missouri or any other state, is that those laws don't always guarantee the same reimbursement. So you can have a law that says that the insurance company has to cover telehealth for X kind of visit if you're going to cover it in person, but they may reimburse at a lower rate. And so organizations just want to know as you start to build more and more into the telehealth world, what is the current state, and then what kind of advocacy can be done to push us towards a future state, something that might be better, where all these advantages, potential advantages we've talked about reaching people through telehealth, can actually be realized, so we can get barriers out of the way. So I just wanted to tell you it's a patchwork, like many laws in the US, it's a patchwork across states, how aggressively they've worked on telehealth parity.
Mm-hmm. Thank you for adding that. The next question is from Edna. How can hospitals incentivize providers and patients to keep the gains in use of technology once COVID is over?
Well, I think that the biggest thing that's going to incentivize is that telehealth can create as good or a better experience for the providers as well as the patients. In my organization, our telehealth visits have always been at or above in-person visits on patient satisfaction. And by reports, the providers receive just as much satisfaction from those visits. I've had a list of 20 or 30 providers over the past 2 or 3 years waiting to get into do telemedicine with our group, because they just are excited by the technology and the ability to provide care in that different way, with just an understanding that this is the way things are going to go. But it also is important to recognize that this is one way that physicians and other providers are handling the burnout mode, that so many physicians are leaving their regular practices and going into telemedicine to work for a company or to start their own practice, because it seems to fill a niche where there is an ability to continue having purposeful patient encounter, but not receive the same burnout factor at their regular practice. So just doing the visits themselves, it can incentivize enough. And there are, I know, a large majority of our providers, having had to switch to telemedicine by necessity for COVID, who are planning to continue doing telemedicine when the requirement is over. And it will be interesting to see. There's always a spectrum of how many people take to it and how many people said, I'll never want to do that again. But I do think that we're going to see the vast majority of providers moving in that direction, just for the sheer satisfaction that it gives.
Perfect, thank you. This next question is for Gabriela. What do you use to record your instructional videos for patients? How to use the app, etc., those videos that you were referencing. It looks like Christina from Catholic Charities is interested in making communication videos for clients and are curious what platforms or technology others use to make these and edit these videos. That's a good question, Christina.
Yes, so the reference to the video that we did that was not professionally done, we just simply used an iPhone. And I don't know the name of the video editing app, but they're out there. You can just download them and you can edit your videos. We are fortunate in that we have sort of an in-house public relations department that uses more professional video. And then what we're doing is we're just posting it. Not currently, but in the future, we're going to post them on our website, so they'll be available there.
Perfect, thank you. So we'll be looking forward to those, and maybe if you are posting them to your website, maybe you can share them with the CCIR and we can push those out as well. Dr. Johnson,
Yes.
I'm going to say, oh, sorry, Gabriela, go ahead.
I just said yes, absolutely, we'll do that.
Perfect. Thank you, Gabriela. That's a great idea. And I see a lot of people are going to be interested in that idea and making sure that patients have access to those step-by-step directions that are so important. All right. The next question is from Ann Routh from Mercy and Truth. Is there a good resource that we could see some cultural challenges with technology by ethnicity? For example, the Congo versus Burma versus Somalia. Do any of our panelists know of any resources that might be helpful, or even any of our attendees that want to write some resources in the chats would be great as well.
I'll just say quickly, this I don't have any specific resource to offer, but I have looked some recently as we've met in this telehealth and health equity group, at what articles are out there already around how telemedicine or telehealth has been either taken up and accepted or not by different groups, by different immigrant groups or different language groups, for example. And so out in kind of the academic literature, there are some articles about this. There aren't a lot, but there are a few. So I guess to say, I was hoping to find something similar where someone had done a review and kind of described, what experiences people had had. I haven't found anything like that. But certainly I'm going to stay on the hunt. And if we find something, we'll, through the CSER website and through our Children's Mercy website, public site, we'll be able to share anything we find.
Well, and thank you. And I think this is also a great opportunity, part of the forums that we have, to be able to identify what needs are out there so that all of us as direct service providers can be better equipped with up-to-date resources. So Anne, although we don't necessarily have any specific resources that I can see right now, you bring up a very good point and something that we need to look at and see and be creative for us to create those for our community members. Thank you, Anne. All right, our next question is, can equipping patients with connection to telehealth happen during the first visit?
Yeah, it can. We have a telehealth platform, which is where the patient initiates the visit for an on-demand urgent care visit. So the patient can click on the link and go through the patient journey, including their demographic information, and go to a virtual waiting room and wait for the physician to come to them. And they connect right there on a video conference call within that, quote, virtual waiting room. And so that is where the patient initiates the visit, and that's how our PCN urgent care platform works. And as long as they find where the link is, then all they have to do is click on the link, then go through it.
All right, perfect, thank you. The next question is from Libet. For Children's Mercy and Truman Medical Center, do you have direct lines for Spanish-speaking families to call to be immediately connected with an interpreter?
Hi, this is Gabriella, and we do. Our direct phone number is 816-404-3280. The other way to connect with a Spanish-speaking scheduler would be just by dialing 404 for TMC. You have the option of pressing 2 for Spanish, and then the line rings directly to our cultural health navigators, who can also help you with scheduling your scheduling.
For Children's Mercy, we have a couple of things. One is that we have patient guides, Spanish-speaking patient guides that can be accessed. I don't have that phone number right here off the top of my head, and that was a program that's been built up over the years and spread farther and farther. And so I haven't kept track on where the phone number is now. But anyway, yes, there's a line. I'm sorry I can't share it, but we can share that information again afterward to attendees. And that patient guide is not just an interpreter, but is meant through the process of getting to the place you need to get to within our phone system. In the past, we found the problem was that someone might call and be passed on, be forwarded, to another number, and then hit a dead end where they hit a voicemail box and nobody ever calls them back, or they hit a English-speaking employee who didn't know what to do. And so we decided to have almost just like a phone navigator through the phone system who could do warm handoffs all the way to the place they're trying to get to. So that's one program we have. And then we also have the ability through our other phone numbers to select Spanish and then have that go directly into language services.
Thank you. And I know for several other organizations, healthcare providers, there are individuals that speak Spanish and English directly that answer the phones and have direct access to other languages via different services. And so that's also a great resource for our community members. All right, our next question is for Iran. So I'll give you a moment to unmute. Iran, would you be able to share maybe some ideas with us and our attendees on ways that we are able to reach out to the Spanish-speaking predominant populations in order to have access to, is it social media? Is that the best? Is there traditional media, radio, or other mechanisms that work better? I don't know if you have any insights for us.
I think it depends what demographic you're trying to reach, but I would say Facebook works pretty well because I think on Facebook, like a lot of older people get into, not just young people. I think Facebook works pretty well, but also you can try the radio station, the Spanish radio station. I think that's a good source too that you can use. And I don't know besides those two what else you can use. But for the most part, I think Facebook and the radio can work pretty well.
Perfect. Thank you, Iran, for sharing that. All right, so we are getting close. It's hard to believe that the 2 hours went by this fast, and thank you all for your questions. We have time for 1 to 2 more questions, so we'll try to get through those before we wrap up our time here. So the next question is, can any of the panelists share easy to read or printed resources or videos that we can circulate to educate Spanish-speaking sorry, the question, I can't see it anymore. So let's see, we will move. So anybody have any resources specifically about telehealth that they are aware of that we can hand out to our patients and clients?
Yeah, at Children's Mercy, we have created a Spanish-speaking, I think Burmese and Somali telemedicine, how to get onto our team's telemedicine visits. I will be able to forward that to you, Andrea, and to send out. I don't have access at where I am right now, but yes, we have created that with a little graphic visualization of how to get into our telemedicine system.
That's great. Thank you. That would be wonderful if you can pass that on. So let's see. And just Christina, another attendee, Libet, was sharing that they do their videos from their own phones and then share them on their Google Drives. And there's no need to download anything, and it's free to use. So that's another resource that you could use for making your own videos within your organizations.
Andrea, can I just jump in with one quick thought on the previous question about either videos or printed instructions for individuals to be able to learn more about telehealth? Each organization, of course, will probably need their own, depending on what platform they use, because the details of how to do it could vary. But there also are some videos available out on YouTube and elsewhere that have a more general description of what telehealth means or what telemedicine is. For example, in Spanish are the ones I've seen most often. So doing a search for something like telesalud, ¿qué es telesalud, or things like that will turn up a number of pretty good resources, and those could be of use to organizations who in the immediate, have an immediate need to have something to show people or pass along while they're working on their own process, kind of video like we've heard about.
Perfect. That's a great resource. All right. And then just one last comment that Mary Lou Jaramillo has shared. Thanks to all for this valuable discussion and information. Knowledge is powerful. After today's discussion, it's clear to me that telemedicine and telehealth is the future. Has CCIR considered inviting Kansas Health Foundation, Kansas Leadership Center, Kansas Hispanic Latino American Affairs Commission, which Aude Negrete was on our webinar the last time, and the radio such as La Mexicana station in Liberal. So Mary Lou, you bring up very good points, and we are always through the CCIR looking for ideas on speakers to bring in or other folks to engage in our network. After this, you will be getting a survey link that will direct you to a Survey Monkey, and in there we do have a space if you have other topic ideas or specific speakers that we can bring in. We would be open and love to hear that information from you all as we anticipate doing more webinars such as these in the coming weeks. So anything else that the panelists want to add to that? Okay, perfect. With that, it looks like we are coming up to the end of our time. I just want to give a big round virtual applause to all of our panelists and to, yes, thank you, Celia, to all of our panelists and to Celia for moderating this important discussion, and Iran for sharing your perspective. We are very grateful for your time and your insight. Virtual round of applause. And Gabriela, thank you for sharing those tangible items that I think many of us are going to learn from today to take back to our organizations and implement. So we, like I mentioned earlier, at the end, after clicking off of this webinar, you should receive a link directly to a Survey Monkey. And we know that all of you are busy, but would love to hear your feedback and insights onto future webinars or topics. We want to hear from the things that you all are dealing with as being direct service providers or working in hospital, clinics, social service organizations. And so please keep us updated. Please also visit our website at ccirkc.com and follow us on Facebook so that we can all keep connected and share up-to-date information to then distribute those to our families. And with that, anything else, panelists, that you would like to say as we close?
I just want to say thank you. Thank you. I was able to help, and I'm glad. I'm glad you guys trying to make this work better for the patients. Thank you.
Thank you. Yes, you can see that we have a very talented team of individuals, not just on the panelists, but also attendees on the call that are really trying to work hard and learn from one another to make your experience better. And many of us had to put some things together very quickly in order to respond to the patient needs. And so we just appreciate everybody's patience through that as well. So with that, we will sign off, and just a big thank you to everybody, and thank you for all the work that you're doing in the communities to serve our patients and clients. And it's been amazing through this to see how everybody has collaborated and have the best intentions of our patients in mind at the end of the day. So thank you all again. Have a wonderful, wonderful Thursday. Take care.